Were you waiting on me? Let's get going. According to a 2025 survey, the average wait time for a medical appointment in large metropolitan areas in the United States was 31 days. That's up from 26 days in 2022 and up from 21 days when the survey was first conducted in 2004. Wait times in U.S. healthcare are the topic of this week's Healthcare Triage. Let me put you back on hold for a second. You live in the United States. You have health insurance. You figured out where to find a list of doctors your insurance is willing to pay for. You call one to make an appointment. You're feeling responsible. You're feeling proactive. You're like, look at me, engaging in preventive care. And then they say, great, we can see you in 6 weeks. And you're like, cool, I will simply remain alive and unchanged until then. I guess if we didn't have a shortage of medical providers, I'd be able to get in sooner, right? That's a really common explanation, and it's not wrong, but it's also not the whole story, not even close. Wait times in healthcare are what we get when we mix supply, demand, and a whole bunch of system design choices together, and then basically let them fight it out. We'll start with supply, because that's the one everyone jumps to. Yes, there are physician shortages. Training doctors takes a long time, trust me. Residency slots are limited by policy, and some specialties like primary care don't pay as well, so fewer med students want to go into them. But even when the total number of doctors looks right on paper, people can still wait a really long time to be seen because the number of doctors we have is only part of the equation. It's also about where they are, what they're doing, and how their time gets used. Starting with the where. Doctors aren't evenly spread out. They tend to cluster in certain areas like cities or wealthier regions, while rural or underserved areas have fewer doctors. Then we've got the what. Within the same city, you might have a lot of specialists, but not enough primary care family physicians. So you can have enough doctors overall and still not have the right doctors in the right places. And then there's the how, meaning how doctors actually spend their time, and a lot of it is not with patients. That sounds nuts, but they have to set aside huge chunks of time for the administrative obstacle course that is modern healthcare. Data from the American Medical Association suggests that in a 58-hour work week, only 27 hours, less than half, were spent directly caring for patients. Where does the rest of that time go? Well, if you were thinking about going into medicine to avoid paperwork and emails, I've got some bad news for you. The time goes to tasks like documentation, managing email inboxes, and paperwork for stuff like prior authorizations. That all eats into the number of appointments that can exist in the first place. So it isn't always that we don't have enough doctors. Sometimes it's that we haven't structured things so that doctors we do have are distributed and used in the way that patients actually need. Now let's talk about demand, because there's a lot of people who need care and that number's going up. People are still making new people all the time. The population is aging, chronic conditions are more common, and people are more connected to the healthcare system than they used to be. Importantly, demand isn't just about need, it's also about how the system nudges people to use care. Take insurance, for example. When people get coverage, they use more healthcare. That's generally a good thing. It means people are getting the care that they might have skipped before. But it also means more people are trying to book appointments with the same pool of providers. On the flip side, coverage with higher out-of-pocket costs can make people delay care. That sounds like it would reduce demand, but really it just delays it. When people finally do see a doctor, they're often sicker, which can mean more visits, more time, and more resources. Also, not all demand is the same. Some people need to be seen quickly, while others could safely wait. Some things could be handled in primary care, while other issues need specialists. But the system isn't always great at sorting that out efficiently. Everything kind of ends up in the same scheduling blender. Which brings us to the part that matters the most. How the system is actually designed, because this is where a lot of the magic, or maybe chaos, actually happens. Take scheduling. Many clinics book appointments weeks in advance and fill every single slot. On paper, that looks efficient. In reality, it means there's almost no flexibility. So if you wake up sick tomorrow, there's nowhere to put you. You either wait or you go somewhere like an urgent care or emergency department, which isn't ideal. Once, the husband of our writer, Tiffany, got in a motorcycle accident. He had a fairly serious leg injury and was told by a specialist to come in immediately if there were any signs of infection. A few days later, when there were indeed signs of infection, the specialist had no available appointments. Since a blood infection is nothing to mess around with, the emergency department was the next stop. The very overwhelmed emergency department physician ended the visit by telling Tiffany and her husband that the emergency room should be reserved for true emergencies, like gunshot wounds. Clearly, that isn't the largest reason that emergency room visits shouldn't be replacing doctor visits, but isn't it a fun story? So anyway, payment systems matter too. In a fee-for-service world, providers get paid for doing more billable things. That shapes how time is spent, what kinds of visits are prioritized, how long appointments are, and even which specialties grow faster over time. And all of that feeds back into wait times. There's also the question of who's allowed to do what. In some states, nurse practitioners and physician assistants handle a lot of routine care, which can expand access. But in other states, rules or norms limit that, which means more pressure on physicians and fewer available appointments. Then there's coordination, or let's be honest, the lack of it. Things like referrals and repeat tests create bottlenecks. Every step adds additional time, not just for you, but for everyone else in line behind you. And now for the dramatic reveal. Wait times are not unique to the United States. They're not even unique to any one type of healthcare system. You see them in systems with private insurance. You see them in single-payer systems. You see them in hybrids. I know you're screaming at me right now because what am I talking about? Everyone knows Canada with their single-payer system has terrible wait times, and that's why the U.S. healthcare system is the superior option of those sole two options for a healthcare system on planet Earth. Do you hear the sarcasm dripping from my voice? But I digress. At the end of the day, there are always limited resources and more potential demand than those resources can instantly handle. Every system has to make trade-offs. Some systems rely on prices. If care is expensive, fewer people use it. Others rely more on queues. People wait longer for non-urgent care. Neither approach eliminates the problem, they just handle it differently. But importantly, long wait times don't automatically mean the system has failed. They mean the system is making choices about where resources go, how care is delivered, and who gets seen when. Sometimes those choices are thoughtful. Sometimes they're accidental. Sometimes they're kind of terrible. We want more of them to be thoughtful. If we want to fix wait times, we have to understand what's actually causing them. We can think about how to get clinicians into underserved areas. We can rethink how we pay for care and how much. We can improve scheduling, reduce administrative burden, and make better use of team-based care. And yes, when necessary, we can think about how to increase the supply of physicians. But healthcare isn't just a system where you pour in more doctors and magically get perfect access. It's a system where structure, incentives, and human behavior all interact in complicated ways. We can't make it work better by focusing on a single piece. Instead, we just need to be a lot more intentional about how it all fits together. But systemic changes take a lot of time and effort, so you'll just have to wait a minute. Academy Health is all about making research matter, turning evidence into real-world impact on health and healthcare. That's exactly what Healthcare Triage is about too, breaking down the complex, sometimes messy, health policy and research stories that affect all of us. Basically, we're tired of the nonsense, and that's why we've teamed up to bring you this important series. Let's fight the nonsense together. We'd really like it if you'd like the video and perhaps subscribe to the channel and go on over to patreon.com/healthcaretriage where you can help support the show and make it bigger and better. We'd especially like to thank our research associates, Edward Loyaholm and Christopher Learn, and of course, our Surgeon Admiral, Sam.